Next in our discussion is childhood and adolescent bipolar depression. As we know, the reason why this is called bipolar disorder is because it has two poles for this mood disorder. You have the depressive episodes, and you have the manias and the hypomanias. Now, people with bipolar disorder, as well known, spend roughly 2/3 of the time of their illness in depression. And this is why most of the struggle in life in someone with bipolar disorder is the struggle with depression. Like adult literature, as we talked about children with this condition, the data on effective treatment for bipolar depression, unfortunately, is not that available. Treatment of bipolar depression is a clinical challenge in children the way it is with adults. And this is due to a number of factors, which I'll try to summarize here. The first challenge from a clinical standpoint is the risk of switching to mania, or acceleration of cycling of the mood episodes, the two poles, whether the depression or the mania, when we use antidepressants, who in turn, in themselves, have a questionable efficacy in bipolar depression per se. Now, although there is possibly less switching when using certain medications, such as more serotonergic agents, more than noradrenergic agents, so using an SSRI, for example, would be better than using a tricyclical antidepressant or a SNRI. Switching is more common in antidepressants in general, even though SSRIs might seem a little better option, but switching is more common in children and young adults than in older adults. The second clinical challenge and aspect of the treatment of bipolar depression in the youth is that, with the exception of lithium and quetiapine, which can be effective as monotherapies, there is often a need to use polypharmacy and combine medications together. Now, that in itself imposes an increased risk of childhood obesity and diabetes with this combination, say, for example, of an atypical antipsychotic with an SSRI. The third clinical challenge is that there is a lack of clear guideline as to how long to keep antidepressants on board for someone with bipolar depression, especially after symptoms resolve. Do we keep the SSRIs on, for example, or do we take them away? And this, mind you, is an important thing to keep in mind just because of the risk of switching. And this in itself, as we said, is a little more frequent in youth more than adults. Hence, we have to discuss the pros and cons of keeping an antidepressant medication with the clear advent of helping depressed mood versus taking it away and risking a recurrence of a depressive episode. What are some of the agents that are worth considering in childhood bipolar depression? In the NICE guidelines, there was a meta-analysis of pharmacological interventions that met criteria to be included in analyses. Those are the studies that met the burden that the NICE network set as a standard for their analyses. They found that there are only 6 treatments that have superiority to placebo, including lurasidone, valproate, quetiapine, fluoxetine with olanzapine alone, and lamotrigine. Interestingly, valproate was received by the lowest number of people in the analyses, and lamotrigine was the most tolerated and the least likely to be discontinued. Imipramine, lithium, moclobemide, paroxetine, and ziprasidone were actually not superior to placebo. It is worth noting that only fluoxetine plus olanzapine in combination and lurasidone are FDA approved for treatment of acute pediatric bipolar depression. It is important to note that the data we have on lithium for off-label treatment of bipolar depression is based on an open-label study, not a randomized controlled trial. So how effective is lithium for bipolar depression? In a study that included 27 adolescents with an episode of depression with a bipolar disorder diagnosis, there was an open-label study that gave 30 milligrams per kilograms of lithium twice a day, and they adjusted the dose to a therapeutic serum level of lithium of 1.0 to 1.2 milliequivalents per liter. To check for the effectiveness of this intervention, they included rating scales such as the Children's Depression Rating Scale, the revised version, and the Clinical Global Impression Scales for bipolar disorder. What were the results? The results showed that scores significantly decreased from baseline to endpoint, resulting in a large effect size of 1.7. Response and remission rates both seemed to be better. For the response, it was roughly about 48%, and for the remission, it was roughly about 30% of this patient population. To summarize, bipolar depression is equally, if not more challenging of a condition to treat in children than adults with bipolar depression. The second point is, only 2 FDA-approved agents are there, and these are namely lurasidone and olanzapine plus fluoxetine. The third take-home point is that lithium might be very effective and should be seriously considered as an option, although this continues to be in need for more evidence from research in this population.